Good day, dear viewers. Today our topic is bronchial asthma, what it is and how to treat it. But first, subscribe to the channel, hit the bell, and give a like, and let's get started. Bronchial asthma is a chronic inflammation of the airways that makes the bronchi hypersensitive and prone to spasm. When a person inhales an irritant, dust, cold air, smoke, or a strong odor, the bronchial walls swell, the surrounding muscles contract sharply, and thick mucus appears inside. As a result, the air passage narrows, a wheezing sound occurs during exhalation, and it feels as if the chest is weighed down by a heavy stone. Asthma is not an infection and not a leftover of an untreated cold. It is a kind of immune system glitch that occurs more often in people with a family tendency to allergies. If you or your relatives have seasonal rhinitis, eczema, or food allergies, the risk of asthma increases. However, even without genetics, the disease can develop when a child spends many years exposed to tobacco smoke or constant urban smog. Global statistics say that about every 10th school-age child and roughly 5% of the adult population has asthma. In most patients the disease starts in childhood, but first attacks can appear in adulthood, especially if the person works in harmful conditions. Sometimes asthma masquerades as a persistent bronchitis, and such a patient treats cough with syrups for years without knowing the real cause. The brightest manifestation of asthma is an episode of breathlessness. A person cannot fully exhale, instinctively leans forward, rests their hands to help the chest, and breathes quickly but shallowly. A dry cough is often heard, which does not bring relief. An attack can last from a few minutes to hours and passes either on its own or after using a bronchodilator inhaler. But asthma is not only crises. Inflammation smolders even on days when there are almost no symptoms. The constant background process gradually thickens the bronchial walls, reducing their inner diameter. That is why the modern treatment strategy changes the focus. We do not wait for attacks. We suppress inflammation every day so that attacks do not arise. Without regular therapy the bronchi become less flexible, persistent shortness of breath appears, and it is much harder to restore normal function. Thus, bronchial asthma is manageable but not a temporary problem. Proper diagnosis, competent therapy, and the patient's own discipline can make the disease almost invisible in everyday life. Next time we will figure out how to recognize the early signals of asthma and why they must not be ignored. Remember, any recurring shortness of breath is a weighty reason to consult a pulmonologist. Especially if you hear wheezing during exhalation, wake up at night because of cough, or notice that climbing stairs forces you to stop and catch your breath. The sooner you break the chain, irritant, inflammation, spasm, the less damage the disease will do to why. To prevent asthma from controlling you, you need to learn to recognize it before the first serious attack. We will tentatively divide all signals into three groups: daytime, nighttime, and physical. Daytime moments arise in a calm mode, for example, during a conversation. If you suddenly catch yourself wanting to take an unusually deep breath or cough without reason, that's already a bell. Nighttime symptoms are especially significant. Healthy bronchi work quietly at night. When hidden inflammation is present, a person wakes up from a dry cough or wheeze. If this happens twice a week or more, and you have to sit up in bed each time and wait for relief, it is time to see a doctor. The third group is manifestations under load. Ran for transport and had to stop, gasping for air. Climbed stairs and started coughing. It may be bronchial spasm when the need for oxygen rises sharply. In winter, dry cold air intensifies such a reaction. Triggers launch the acute phase of inflammation. The most common are dust, mattress mites, pet dander, mold, and spring pollen. Household chemicals can cause a short contact spasm, and cigarette smoke is enemy number one for sensitive bronchi. There is also occupational asthma, when symptoms worsen at work and ease on days off. Record your observations, this helps diagnosis. An ordinary viral infection or chronic stress can also push the disease's onset. Asthma is classified by severity: intermittent, mild persistent, moderate persistent, and severe persistent. The more frequent the manifestations, the more aggressive the therapy. Your task is to prevent progression. For self-monitoring, a simple device, the peak flow meter, is used. In the morning and evening, exhale into the mini tube, the pointer will show peak flow. Fluctuations over 20% between the best and worst values mean the bronchi are unstable. Daytime manifestations are often perceived as a normal cough. If such episodes drag on for months, and there are allergies in the family, do not postpone a visit to the pulmonologist. Write down in a diary the time of cough or wheeze, possible triggers, well-being assessment, and peak flow results. Thus you will show the doctor the full picture rather than isolated cases. Remember the weekend effect: when symptoms ease outside work, it hints at a professional trigger. Sometimes changing working conditions becomes the best treatment. Regular irritation without therapy starts bronchial remodeling, a process hard to reverse. Therefore, reacting to the first signals is the best prevention of a more severe course. In addition to allergens, attacks are often provoked by viral infections. After an ordinary cold, cough can last for weeks. That's a sign inflammation touched the bronchi. Prolonged stress also plays a role, because stress hormones increase airway reactivity. It is important to track such influences and discuss them with your doctor. Then your action plan will be truly personalized. Take care of yourself. So, asthma is suspected. How to confirm the diagnosis? Let's start with the most important, objective tests. The gold standard is spirometry. You sit down, take a deep breath, and exhale with maximum force into the device tube. The computer instantly calculates the air volume expelled in the first second and other parameters. If after inhaling a bronchodilator these numbers increase by at least 12% and 200 milliliters, this is clear evidence of reversible bronchial narrowing, and therefore asthma. Peak flowmetry is a home mini version of spirometry. In the morning and evening you exhale into a pocket tube, the pointer shows peak flow speed. If fluctuations between the best and worst value exceed 20%, the bronchi are unstable. We keep a diary, record numbers, time, possible triggers. Such a map helps the doctor track dynamics and adjust treatment. To clarify the allergic nature, skin prick tests are done. Drops of standard allergens are applied to the forearm and the skin is lightly scratched. After 15 minutes we look, a will over 3 mm compared to control is positive. An alternative is a blood test for specific IgE. FeNO measures exhaled nitric oxide. Elevated gas levels indicate eosinophilic inflammation typical of allergic asthma. The method is especially useful when spirometry is on the edge. A chest X-ray or CT is used not to confirm asthma but to rule out other causes of wheezing, pneumonia, tuberculosis, tumors, foreign bodies. In most patients with uncomplicated asthma, the image will be normal. In children under 5, spirometry is often impossible, so the diagnosis relies on typical symptoms, family history, and a trial course of inhaled corticosteroids. If cough and wheeze disappear after a month and return after withdrawal, this is a diagnostic test, with medication. Remember, the earlier the diagnosis is established, the faster you will gain control over inflammation and stop bronchial remodeling. Do not be afraid of instrumental studies. They are painless, take minutes, and save you from years of wrong treatment. Let's move to therapy. Modern asthma treatment consists of 2 bricks, baseline and quick relief. Baseline is taken daily, even if you feel great, it extinguishes background inflammation. The recognized gold standard is inhaled corticosteroids, ICS. The medication lands directly on the bronchial mucosa, so tiny doses are needed and systemic side effects are minimal. Proper inhalation technique is critical. Exhale, grip the mouthpiece, simultaneously press the canister and slowly inhale deeply, hold your breath for 5 seconds. Ask a healthcare worker to check your technique once a year. If ICS alone are not enough, we add a long-acting beta-2 agonist, LABA, in a combination inhaler. It relaxes bronchial muscles for up to 12 hours, while the corticosteroid simultaneously removes inflammation. For some patients, leukotriene receptor antagonists are available, tablets that block a certain inflammatory pathway and are useful when asthma is combined with rhinitis. In severe allergic forms, biological drugs, monoclonal antibodies against IgA or interleukins 4, 5, 1, 3, are used. They are administered every 2 to 8 weeks in the hospital. They sharply reduce exacerbations and allow lowering the ICS dose. The rescue inhaler is a short-acting beta-2 agonist, SABA. It is needed only during attacks or before physical exertion if it provokes bronchospasm. If you reach for SABA more than 3 times a week, consult your doctor. Baseline therapy is insufficient. There are also systemic corticosteroid tablets, but they are prescribed in short courses during exacerbations when inhalers are not coping. Continuous use of such tablets is undesirable due to side effects. The patient and doctor together draw up a written action plan. It clearly states which baseline dose to take in a stable period, when to increase it at the first signs of worsening, and when to call an ambulance. The plan is your safety map. Asthma control is not only medication but also lifestyle. Avoid triggers, vacuum regularly with a HEPA filter, ventilate, use dust-proof covers on pillows and mattresses, wash bedding at 60 degrees Celsius. If allergic to pollen, keep windows closed on peak bloom days, wear sunglasses outside, and take antihistamines in advance. Physical activity is beneficial. Swimming, cycling, and jogging train respiratory muscles. Take 2 puffs of the rescue inhaler 15 minutes before a workout, and sport becomes safe. Annual flu vaccination and a one-time pneumococcal shot reduce the risk of infectious exacerbations. Smoking is taboo. Even passive smoke increases bronchial reactivity. The peak flow meter is your daily beacon. Record morning and evening readings, evaluate the color zone, green, control, yellow, warning, red, doctor or ambulance immediately. Tracker apps help store graphs and remind you of inhalations. Psychological support is also important. A chronic disease can cause anxiety. Patient groups or therapy sessions teach relaxation techniques and the right reaction to shortness of breath to avoid panic, which only intensifies spasm. Remember, today asthma does not limit dreams. With well-chosen inhalers you can fly, go diving, and even run a marathon. Olympic athletes with asthma are proof. The key is strict adherence to the plan and an open dialogue with your doctor. So, we have sorted out what asthma is, how it manifests, how to diagnose, treat, and control it. Subscribe to the channel, give a like, share the video with friends, and breathe to the fullest. See you in the next episodes.